Okay, thank you so much, and a very good morning to everyone. And thank you, Dr. Yamadri, for this wonderful opportunity and some really nice presentations. And we have really seen the role of scleral buckling is still there in this era. But let me talk about why it has gone out of vogue. So this is the statement that Lister had made way back, almost 100 years back, that treatment of retinal detachments associated with retinal holes should be only urged in only eyes as a last clutch at a straw of hope. So that was the situation way back. And at that time, and then scleral buckling came, and it was the standard of care for a very long time. But now it has slowly receded a bit. So let us understand what are the enemies of the bucklers in the present day. So now we are living in the age of the sutureless. All surgeries we are trying to do without suture. The residents are exposed less and less to sutures, and now we see people have passed their residency, and they are unable to do sutures. So that gives a tendency to avoid surgeries where sutures are involved. Vitrectomy, the counterpart of buckling, the vitrectomy surgery has been the progressive one and has kept on evolving itself with latest technologies, cutting edge viewing systems, and instruments are getting smaller and thinner day by day. So that is another advantage that we get. Where does it give us the advantage that buckling seems to be having extensive tissue trauma and surgical handling, and that leads to delayed recovery in most of our cases. So you can easily identify on the next post-op day which patient has undergone buckling and which has undergone a vitrectomy procedure, say 25 gauge vitrectomy. So intraoperatively, when we come to it, we can see we have the luxury of seeing complete attachment at the end of the surgery. So that gives you a lot of confidence. On the other hand, in a buckling procedure, if there is a lot of cases do attain attachment on table, but where the SRF is thick, it is viscous, it might not settle, or it might take a very long time. And that leads to delayed post-op recovery in some of the patients. Another challenge is identifying all the breaks. So, I mean, we have talked about the indications of the surgery before, but at times the breaks are missed, and if you happen to do a vitrectomy in that case, then that's a boon. So you can identify those breaks intraoperatively with proper indentation and then secure them easily. Another important thing that we can do during the procedure when you are unable to settle or find the break is a drainage retinotomy. That advantage you don't have with the buckling. In similar cases where you cannot identify breaks or you are in doubt, you can always go for a 360-degree laser, and that gives you the confidence. And in select cases, one-eyed patients and cases we are not very sure about all the breaks, you can go ahead with that. So this advantage, again, buckling doesn't give us. And so complicated cases like these would obviously opt for vitrectomy in such cases. Coming to the surgical time, that's questionable because a lot of people who are very proficient with the art of scleral buckling might be able to do that in a very less time, but we tend to think that it'll take longer time doing a buckle procedure, and it might be more taxing to do that procedure compared to a vitrectomy procedure. Again, I don't know whether to call it as an advantage or a disadvantage, but if a thorough pre-op evaluation is not possible due to some reason, or just the clinician is being lazy, if it is not done properly, then buckling should not be attempted or will not give you the desired results. So in that case, an easy way out is always a vitrectomy procedure. All procedures are come with a long list of complications, and so is with buckling. Start with things like road perforation while placing the anchoring sutures, refractive changes, intrusion, extrusion, chances of infection, ischemia, choroidal detachments. A long list of complications are there. I don't mean to say that the vitrectomy procedure doesn't have complications, but yeah, this also counts as a point. So those are my 2 cents. I would like to utilize the rest of the time if anybody wants to counter these arguments, and the rest of the panel can chip in with their thoughts.
Thanks a lot, Dr. Devakant. That was a really enlightening